So it is now noon, so we will go ahead and proceed with our final presentation for this morning from Dr. Amanda Shepard, whom I'm delighted to introduce today. Dr. Amanda Shepard is an associate professor of clinical practice at the University of Washington, where she practices both inpatient and perioperative consultative medicine at UW at the Montlake site. Dr. Shepard is an associate program director for the internal medicine residency program and was my APD when I was in residency, and a fantastic mentor at that. And so in that role, Dr. Shepard directs the just-in-time educational programs, including communication, bedside procedures, and point-of-care ultrasound training, which is our topic today. She has developed, directed, and taught numerous curricula, including the popular POCUS elective that combines deliberate practice with simulation to enhance resident competence and confidence in their work. So, without further ado, Dr. Shepard, take it away. I don't know if we can hear you.
Cannot hear you, Dr. Shepard.
Nope, not hear you. Nope. Nope.
Hear me.
Yes.
There it is. Yay.
It's my favorite song, the Zoom Can You Hear Me song. All right. Well, thanks everybody. Thanks, Dr. Bandari, for such a delightful introduction. I think the only thing that would make this better would be if we could all be together and smear a bunch of ultrasound gel all over and learn in person. I am working on getting our slides going here. Here we go. Okay. All right, everyone. Well, thanks so much for having me. Today, we'll be talking about point of care ultrasound for the inpatient provider. And you've already heard a little bit about me. One of my favorite things to do is teach at the bedside. And so while so much of the point of care ultrasound is taking excellent care of patients, the side effect is getting to spend time at the bedside with our patients and with our learners. And so I hope that you see this as an added benefit as well. Yeah, moving along. Here we go. I have no financial disclosure. So our objectives today will be to describe a framework for using point of care lung ultrasound for the inpatient provider. There are dozens and dozens of ultrasound exams that I would love to tell you all about, but I think of lung ultrasound as one that's easily accessible and really can inform the clinical care of many of our patients. That's why we'll dive deep into that one. We'll look at some of the data for the use of lung ultrasound, and then consider the challenges in incorporating POCUS into your clinical care. So while I could talk for hours about procedural-based ultrasound, today we're really talking about the use of diagnostic ultrasound, and I want to think about it in two separate buckets. Diagnostic ultrasound can be used in synchrony with our physical exam and all of the other clinical evaluations that we do to assess patients. Similarly, folks oftentimes talk about point of care ultrasound as like an extension of the physical exam or like the stethoscope. And using it in a dichotomous way, we're using a point of care exam to answer a simple yes/no question. I use this often at UW Montlake, where I'm taking care of patients who have cirrhosis and present with decompensation, and use it to answer the simple question, does this patient have ascites? Alternatively, and probably with better added value, we can use point of care ultrasound to actually trend the care of our patients. For example, patients admitted with hydrostatic pulmonary edema from heart failure can have dynamic densities of B lines, and the decrease in B lines with an effective therapy actually can occur before the patient's symptoms improve, before the oxygenation improves, and even as a marker of successful intervention. As I alluded to a little bit earlier, point of care ultrasound requires a hands-on component because it's the combination of knowledge, image acquisition, and image interpretation. Only at the intersection of all three of these do we really have the opportunity to meaningfully integrate POCUS into clinical care. But based on the limitations of our virtual talk, we'll be inherently focusing more on knowledge and image interpretation. And I hope that I excite you enough about point of care ultrasound that you find ways to dive deeper into the hands-on session. And thinking about point of care ultrasound first, we think about using a quick, rapidly available tool at the bedside to reduce time to treatment, to improve patient safety, reduce cost, and maybe even reduce radiation exposure to deliver still excellent care for our patients. So let's think about a case. I'm describing a case of dyspnea, and intentionally, this person is not going to have a clear diagnosis by history and physical alone. This person's presenting with worsening dyspnea on exertion. They have COPD, heart failure, and CKD. They've had some sick contacts. They have reduced urine output. Maybe they even have cough with sputum production. And all in all, by history, it's really challenging to know what the etiology of this person's presentation might be. Nevertheless, they're admitted to you for further assessment and management. So this person may have a little bit of tachycardia, they're needing some supplemental oxygen to maintain SATs, and they have an elevated BMI, for example. Maybe on exam, they have some increased work of breathing. Their cardiovascular exam, despite your best effort and all of those physical exam maneuvers you're so well versed with, really still doesn't move the needle much. You're unable to visualize their JVP, and they have pitting edema for all sorts of reasons. On lung exam, due to their COPD, perhaps they have an enlarged thoracic volume. They have increased intercostal muscle use, decreased air movement, and some scant wheezing, just for fun. On labs, they have a little bit of hyponatremia, an elevated creatinine, though at its baseline, and a BNP, which is right in that non-diagnostic level at the upper limit of normal. Look at their radiology, which is a chest x-ray, probably 2 views because they came from the emergency department, and it has diffuse streaky opacities, correlate clinically. So at this point, many of us might try one mode or treat with both a COPD exacerbation and with diuretics to see what happens. But I'm going to show you that the addition of lung ultrasound can actually help you narrow in on your treatment regimen a little bit faster. So what I'm sharing with you is a 3-method lung ultrasound approach. First, where we evaluate the pleura, then we evaluate an interstitial pattern, and finally, we look at the supradiaphragmatic space. So first, when evaluating the pleura, what we're looking at is that very most outer layer of the lung, where the visceral and parietal pleura are opposed. And so the visceral and parietal pleura, as we know, are 2 very, very thin layers that have a small amount of fluid, typically 5 cc's or so, that allows these 2 layers to move freely with reduced friction throughout the respiratory cycle. This is the normal state. You've oftentimes heard POCUS people or ultrasonographers talk about the window. And what we're talking about is positioning the ultrasound transducer so that we can see what we're looking for. So in this example, we're putting our transducer on the patient's chest and looking through the window between 2 ribs. So here you can see that the window frame is a hypoechoic shadow on either side. Pointing this out a little bit more thoroughly, what we're looking at here is this hypoechoic space there, and here are ribs that are then casting shadows deep on your image. Dr. Bandari, can you see my writing?
Yes, I can.
I love it. Great. Cool. So here you see the window, and then this hyperechoic line that's moving back and forth with respiration is your pleural line. When starting out with lung ultrasound, many folks notice that there's a bunch of hyperechoic lines that transverse the superficial aspects of this view, and it can be hard to initially figure out which one is the pleural line. And I've got you. The reason that I know for certain that that is the pleural line right here is it's the one immediately deep to the rib shadow, drawing it all the way across. So there's your pleural line. When looking at the pleural line, there's really three main patterns that we're going to be looking at. The first is the normal lung sliding. And here I see this hyperechoic or bright white line that seems to be moving back and forth with a respiratory cycle. Depending on where you learned lung ultrasound, you may hear things like the shimmering pleural line or ants on a log. All of these are meant to designate that we're seeing movement occur on that hyperechoic space. In the second video, we see rib and shadow, another rib and a shadow, but here the pleural line is really stuck. It almost looks glued together. You can see the intercostal muscles actually retracting with inspiration. They're working really hard to try to inflate this space, but nothing's moving. In this case, the visceral and parietal pleura are not moving and not opposed to one another. And the third most common pattern is this one of lung pulse. Here again, rib with a shadow, rib and a shadow. But now that pleural line is moving in a more kind of pulsatile fashion at the rate of the heartbeat. So what you're seeing here is the visceral and parietal pleura are opposed. There's a respiration right there, but visceral and parietal are opposed here. And what you're seeing is cardiac pulsations that are transmitted to the outer edge of the lung. Oftentimes, pulse means that there is still visceral and parietal pleura next to one another, but not moving with inspiration and expiration. So in summary, normal lung sliding means those two layers are glued next to each other, but they're able to move freely. But when lung sliding is absent, it can be for a couple of reasons. The first one is that the two layers are not opposed. For example, there's air or fluid in between that is going to give you a static pleural line that is not moving. Additional reasons that they may not be moving is that they're stuck together. So for example, in pleurodesis, either surgical or inflammatory for pneumonia, for example, the two layers become adherent to one another and they are no longer sliding. In severe cases of COPD and asthma, the lung can be so hyperventilated that there is not much exhalation. And so you're seeing very little movement due to hyperinflation. And one of the most kind of up and coming uses of lung pleura is for airway obstruction. For patients who are undergoing intubation, for example, a main stem intubation would designate lung sliding on the right, but no lung sliding on the left because there's no ventilation on that left side. So anesthesiology teams are using lung sliding to evaluate for intubation very commonly. You might also use this for aspiration, particularly kind of large aspiration, like choking on a peanut, for example. When evaluating the pleura, we're going to be using gravity as our friend to determine where to look. And so on this semi-recumbent, short of breath person, we're going to be thinking about if they had a pneumothorax, where would the air go? So in an upright person, you'll be looking with your transducer above and below the clavicle, looking at the apices of the lungs. On the semi-recumbent person, typically at about 45 or 30 degrees, that means we're looking just below the clavicle. On a fully supine person, we'll be looking below the clavicle and then typically 1 to 2 more rib spaces cut in, depending on the patient's chest anatomy of identifying where that most gravity independent position could be. The next phase is to evaluate for the interstitial profile. When using ultrasound to evaluate the interstitial profile, what you're looking at with the ultrasound is simply the most outermost layer of the ultrasound. And that outermost layer, a few millimeters deep, determines the dominant artifact. A lines is the normal reverberation artifact, and B lines designate a partially increased density. We'll talk a little bit more about that, as well as consolidation in a minute. So A lines are the normal reverberation artifact. And I think so much about this kid paddle game that you may remember from birthday parties. We've got this paddle, a rubber band, and a ball. And what we're doing with this game is working on getting that ball to return directly to the paddle, exit, and return again. And so this back and forth motion of ultrasound beams is how A-line reverberation occurs. And so here what's happening is a lot of ultrasound beams are coming down to the pleural line and returning back to the transducer. And the ultrasound machine says, aha, a hyperechoic line exists right there. But some of these ultrasound beams return to the line, return to the transducer, but the transducer itself is also a highly reflective surface. And so some ultrasound beams make 2 trips, not as many, but some make 2 trips. And that's why we have this hyperechoic line that appears similar to the pleural line, but is twice the distance, twice the time, and it's fewer. Not as many ultrasound beams made the trip twice. Still some make it 3 times. Again, not as many, but here it is, a second A-line reverberation, so on and so forth. And so the definition of A-lines are hyperechoic horizontal lines emitting from the pleura that decrease in intensity through the distance of the screen. A-line pattern means that the lung is highly reflective. There's a lot of air. Very little ultrasound beam is able to penetrate beyond that pleura. And so that's why you have so much ultrasound power bouncing back and forth. B-lines are the opposite. B-lines are an ultrasound artifact that actually is vertical on our screen. B-lines are a ring down artifact that indicate an increased density at that very first layer of lung. Now, while scientists are pretty confident about how A-line reverberation pattern works, the theories behind B-line or comet artifact is a little less elucidated. But what we think is happening is ultrasound beams are leaving the ultrasound transducer, hitting that part of the lung. But because there's some degree of density, ultrasound beams bounce around for a period of time. In fact, an infinite option amount of time before returning back to the transducer. And that's why you've got these lengthwise up and down comet artifacts. B-lines must originate from the pleura and extend the entire distance of the screen. Normal people can have B-lines too. It's very common to have a few B-lines in those most inferior lung zones right next to the diaphragm. However, you develop a B-line pattern when you have 3 or more B-lines in an intercostal space. This means that at that very edge of that lung that you're evaluating, there is some process that's increasing the density. It's hydrostatic edema, an alveolar filling process like pneumonia, aspiration. It could be alveolar proteinosis or some sort of diffuse alveolar hemorrhage, for example. Other processes that cause this are atelectasis, ARDS, and inflammatory lung diseases. When the consolidation progresses further so that the ultrasound beam is able to penetrate a distance visible to the human eye below the pleural line, that's when we develop a consolidation pattern or a C pattern. On this image, here the pleural line looks pretty hyperechoic and similar to prior lines that we've looked at. But now there's this anechoic circle in the center. That's lung consolidation. The ultrasound beams are able to penetrate through this area of consolidation and then develop something that looks like a ring down artifact. Density on a much bigger scale. Here we have lung that's completely unaerated or deaerated. And it actually, you can see the lower lobe and the middle lobe on this person's lung as they're breathing. So we're seeing here more of a pulse artifact. You're seeing cardiac pulsations move through this person's lung, but the lungs are filled with, they're tissue dense. They're not filled with air, and that is called lung hepatization. Surrounding these 2 lobes of the lung is a beautiful anechoic space or a pleural effusion based on the quality of the hepatization and the anechoic space. This likely is passive atelectasis due to large effusions on that side. And our third place to look at is the supradiaphragmatic space. A lot of lung ultrasound protocols will call this the PLAPS space, which stands for posterior lateral alveolar pleural space, which is quite a mouthful. But what I want you to think about for this is the costophrenic margin on a chest X-ray. This is where the fluid's going to go, the most gravity-dependent space. Here in this clip, with the probe marker facing the patient's head, what we have here is an organ, and based on this being the right upper quadrant, this here is the liver. Now, what separates the abdomen from the thorax, as we all know, is the diaphragm. And so as the diaphragm contracts, the liver extends toward the abdominal cavity, and we see the pleural line coming across with inspiration. So here with inspiration, we see that hyperechoic pleural sliding that comes across the screen. And because the lung is aerated and deflects ultrasound beams throughout, it's actually preventing you from being able to see anything deeper than that lung spot. So this is called the curtain sign, and you can imagine the curtain being pulled across the screen. That's the pleural line being pulled across. This curtain sign helps rule out pleural effusion. Here's an example of an effusion. So similarly, though this is the left upper quadrant, here's a spleen and a diaphragm. And now, as the diaphragm contracts and pulls the spleen more inferior, the lung comes into view, but we're able to see the entire hyperechoic curvature of the diaphragm there. And the reason we're able to see that is the anechoic space of the pleural effusion allows ultrasound beams to penetrate deeper into the thoracic cavity. Now, I'm excited to tell you that lung ultrasound has better sensitivity for pleural effusions than chest X-ray. Some lung ultrasound users have been able to have a sensitivity of up to 100% for pleural effusions as little as 50 cc's. Chest X-ray is thought to need at least 150 or more cc's of fluid before it's identified on a chest X-ray. When considering doing lung ultrasound, many published lung ultrasound scanning protocols have been developed. The blue protocol was the first, and that's this image here. Lung scanning protocols vary in how many zones you ultrasound. Where do you ultrasound them? What position is the patient? Are you looking anterior, posterior, midclavicular line, axillary line? Every time a study has evaluated the utility of lung ultrasound, oftentimes they've developed a new protocol or used already developed protocols to assess the tool's ability to improve diagnostic certainty. Unfortunately, or however, there is very little / no studies that look at head-to-head comparisons of different protocols. And so while major national organizations like Academic Internal Medicine, ACP, SHM, all recommend the use of lung ultrasound, no organization has recommended a particular protocol over others. The use of your protocol is probably based on what did you learn and how did you learn it, as well as your practice type. For example, critical care physicians oftentimes are unable to rotate their patients posteriorly to look at a lot of posterior zones due to the critical illness. However, during the pandemic and evaluation for COVID, oftentimes early COVID signs were in the posterior zones, and so COVID protocols typically focused on posterior zones. The purpose of all these protocols, though, is to put this together. It's to put together the pattern recognition of different pathologies and lung ultrasound findings. So, for example, our patient is presenting with maybe COPD versus pulmonary edema. In differentiating his case, we'd expect that both patient cases should have lung sliding, but what we'll be noticing is either a gravity-dependent B-line pattern with effusions or an A-line pattern without effusions. And so knowing this pattern will hopefully help us determine what our patient's next course of action might be. Let's next dive a little bit into evidence for lung ultrasound. And we're first going to look at the use of lung ultrasound in identifying patients presenting with acute decompensated heart failure. So I like sharing this study first because it's a little bit goofy, but also helps identify the kind of physics or the purpose behind identification of B lines. So remember, B lines are those hyperechoic lines that extend through the screen that designate increased lung density. Well, this study looked at 20 patients who had undergone cardiac surgery within 24 hours. And because they had undergone cardiac surgery, they still had lines in. They had a Swan-Ganz catheter as well as a femoral catheter. Using advanced technology of thermodynamic and thermodilutions, they were able to estimate a patient's extravascular lung water. They were looking at total thoracic volume and then were able to extrapolate extravascular lung water. They were also measuring wedge pressures with PA catheters and simultaneously obtained lung ultrasound. And as you can see here, extravascular lung water and wedge pressure were well correlated to the number of B lines present. This study looked at the use of lung ultrasound in improving the diagnostic accuracy of differentiating patients with acute decompensated heart failure versus non-cardiac dyspnea. So this trial looked at 1,000 patients, half of whom were admitted to community hospitals and half of whom were admitted to academic centers. This study did look at emergency physicians, as most point-of-care ultrasound research was derived from the emergency literature initially. And it looked at the diagnostic accuracy of using lung ultrasound in addition to clinical workup or chest X-ray alone. So what happened here was emergency medicine doctors did an initial clinical workup and made a diagnosis. They then went back and used lung ultrasound to augment their clinical work. And as you can see here, lung ultrasound, in addition to clinical workup, performed better sensitivity and specificity than clinical workup alone. Afterwards, researchers looked at the lung ultrasounds alone and look at chest X-ray alone and saw that as a post hoc, that neither of those were as useful of a tool than the lung ultrasound plus the clinical workup. A subset of these patients, about 400, also had BNPs, and the researchers looked at the use of the BNP, which also performed not as well as lung ultrasound with or without the clinical integration in identifying patients with acute clinical heart failure. And then after the patients admitted, this study looked at the use of ongoing B lines at the time of discharge to predict readmission. And so here, patients within 24 hours of discharge were ultrasounded and the number of B lines were recorded. Looking at various different cutoffs, greater than or less than 15 B lines were used as the dichotomy to look at readmission. So as you can see in this Kaplan-Meier curve, patients who had more than 15 B lines still present at the time of discharge were more likely to be readmitted. And further in this article, were more likely to have a higher 60 and 90-day mortality. Unfortunately, this was an observational study, and so they did not look at, okay, patient has a lot of B lines and I was planning to discharge them today. What happens if I continue their diuretic plan and see if I can decrease B lines later? This may simply be a way of designating who has more severe illness and more diuretic refractory disease. That was a whole lot about heart failure. Let's look a little bit about the evidence for pneumonia. So in this study, this is a meta-analysis of published POCUS literature up to 2014, and they compared the accuracy of lung ultrasound in the diagnosis of pneumonia for adults presenting from the community versus chest X-ray. And as you can see here, the use of lung ultrasound had better sensitivity and specificity, as well as less standard error than chest X-ray alone. Now, these patients were all adults that were presenting with community-acquired pneumonia, and the gold standard here was a CT scan. All right, the last research. All right, last one. I hope I've convinced you that lung ultrasound is great, but in this systematic review of original research from 2017 to 2021, so this is kind of the most up-to-date stuff we've got going. This looked in comparing point-of-care lung ultrasound versus chest X-ray against CT as the gold standard, but not just in adults and not just in community-acquired pneumonia. This systematic review looked at pediatric patients, adult patients, as well as patients who fit their geriatric criteria of over 65 and presented with all kinds of pneumonia, viral, bacterial, as well as hospital-associated and ventilator-associated. And this study showed that overall lung ultrasound had a sensitivity of 92% and a specificity of 81% for all of those combined. I do think it's really important, though, that we point out that the sensitivity of lung ultrasound was still only 92%. And so for your patients who have a high test, high pre-test clinical probability that they have pneumonia, lung ultrasound on itself is not enough to rule out pneumonia. Why might that be? Well, that's because probably we're ultrasounding just the very edge, the very external portion of those lungs. And depending on the lung ultrasound protocol you're using, you're really only visualizing the area in which your transducer is pressed up against their skin. As I shared earlier, there's a bunch of different protocols, some of which have many, many, many scanning zones or lawnmower, where you're literally looking in each intracostal space throughout their entire chest. So back to our case. We first started with looking at lung sliding. And here is a beautiful picture of the pleural line where we have two ribs that are casting shadows down, and we're able to see that lung, that pleural line sliding back and forth. We started at the apices here, and at the apex of both lungs, we're noting initially that there's A-line reverberation on multiple spaces at the bilateral apices. But as we moved into more dependent areas of this person's lung, we noted that there was an increasing number of hyperechoic artifacts or B-line comments that extend throughout our display. When looking at the supradiaphragmatic space here on the right, we're able to see liver here. Liver on the right. And as this person is breathing in and out, I'm noticing two things. I'm first noticing that there are B lines extending down, and there's more than 3 in this space. I'm also noticing that there's a small, albeit present, pleural effusion. Let me see if I can stop it so you can see it right here. On the left, so here's spleen here, we're seeing the patient breathing in and out. And again, here's a very small pleural effusion, but it's present. It was not visible on chest x-ray. And so while we appreciate that there needs to be at least about 150 cc's of pleural effusion to detect on chest x-ray, by doing lung ultrasound for this patient, we're getting a sense that there's gravity-dependent B lines and bilateral pleural effusions. So based on our case, he has normal lung sliding, A lines in the apices, but B lines in the bases, and small pleural effusions. We can then go back to the blue protocol here. Again, this was one of the original lung ultrasound protocols. Based on having lung sliding and a B profile, it brings us to pulmonary edema. When using the blue protocol, according to the researchers here, this decision tree reached accurate diagnoses in up to 90.5% of patients. All right. So maybe I've convinced you that lung ultrasound is super fun, clinically diagnostically relevant, and easy to use. Relatively speaking, it's cheap, it has no radiation, and really what it's all about is your time and expertise. So how might you go about further developing your ultrasound training? Well, my first hope is that you'll find local mentorship. So my local mentor, Amy Morris, took me on many ultrasound rounds, witnessed my exams, coached me along, and then has provided really helpful feedback on my assessments and quality of my images. Additionally, I attended a lot of local or regional conferences where they offered both didactic as well as hands-on experiences. I know ACP has had several hands-on POCUS experiences locally and regionally in the past. And then there are several national POCUS programs. And so I want to take a quick minute to talk about the ACP's POCUS pathway. So ACP has a POCUS pathway that includes a hands-on, in-person 2-day session where you get the opportunity to learn from great POCUS people and have scanning of live models, figuring out all of the hands-on, how to work the machine, how to get the image, and how to interpret it. It also has built into it POCUS mentorship. And so there's someone that you're paired with that then provides you feedback and coaching along the way through your POCUS journey. All right, folks. In summary, I would like you to walk away knowing that ultrasound first is an effective diagnostic approach for patients with undifferentiated dyspnea. That lung ultrasound, when used in a clinical evaluation, can outperform chest X-ray and BNP for differentiating cardiac dyspnea. And that point-of-care ultrasound skills, when built with hands-on experience and feedback, are super fun, and I encourage you to find a POCUS coach.
Thank you so much, Dr. Shepard. Having witnessed your POCUS skills in real person, I gotta say this is awesome that at least we get a taste today virtually. Um, I wanted to just ask a couple of questions, if you wouldn't mind.
Please.
First is, can you kind of go over one more time how one would discern when you're looking at the pleura, how you would discern whether there is air occupying that space versus a pleurodesis? I think getting identifying fluid, just to my eye, seems a little bit easier because you have that giant hypoechoic region. You can see lungs sort of flopping around in what looks like a fluid bath. But what about about air versus an adherent set of plug.
Yeah, great. I love that you've asked that question. And in real life, it sounds like make it sound easy, but it can be tricky. And so when the visceral and parietal pleura are opposed and freely moving, that means that you have lung sliding, right? But if there's a pneumothorax, there's air between the two, then you will have no lung sliding. But because there's air here, you still have A-line reverberation artifact. The ultrasound beams still come down and reflect off of that air and create A-line artifact. So pneumothorax is going to have no lung sliding and A-line artifacts. Cool. Let's say there's a fusion there. So you're looking at the pleural line. It's not sliding, but your brain is already looking at that anechoic space deep to it. You're seeing that pleural effusion. Maybe you're seeing even deep to that consolidated lung. And so seeing pleural effusion, no lung sliding, is pretty easy to differentiate. But you asked the tricky one, which is how do I know if it's an adherent pleurodesis? And we see this oftentimes in folks who have inflammatory lung disease or a complicated pneumonia, for example. And in those cases, it's a little tricky, but some clues are, again, visceral and parietal pleura are opposed and there's no lung sliding. But oftentimes in those circumstances, the lung itself has increased density and you'll have B lines. And so whenever there is a B line, that means that the two are opposed. Even if you don't see sliding, B line presence means that the visceral and parietal pleura are adherent.
Awesome. That's helpful. Thank you so much.
Yeah.
And then another question for you is how do you advise trending B lines if you're trying to assess for improvement in your treatment? And is there like evidence that we could potentially target like a certain number of B lines getting down to 3 or less? Or may some patients just have a baseline elevated number of B lines when they're dry?
I was so hoping you would ask about counting B lines. There are studies out that look at our accuracy between interrelators and deciding, is it 7 B lines or is it 6? And it turns out that our interrelator reliability is not good. But if we said few, many, or consolidated, we agree on that. And so there's that evidence there. AI is counting our B lines. So many of these machines, not associated with any particular brand, many of these machines now have AI features that count your B lines. I found them to be not helpful at all because I'm still going to decide if that was a B line on my own or not. So I think that in general, the absolute precise number of B lines, while useful in looking at the literature and figuring out clinically, when I'm looking at it from day to day, I'm making a note of several B lines or 5 to 7 B lines or something like that, and using that as my trend, looking in the same position with or same intercostal space with the patient in the same position. As for should we be targeting few/no B lines before discharge in a patient with heart failure? That's the study I'm looking for because I don't know yet. We've seen this observational study of persistent B lines at discharge increases risk of readmission and mortality, but maybe that just means that this person's heart is so sick that they require higher filling pressures, and that is actually simply a marker of worse disease. I don't know. I'm hopeful we can figure that out.
Thank you. And one more question for me. If there are others, please feel free to send them via the chat or the Q&A. I'm curious to know, in your role as an educator, do you have a sense of, are other programs around the country also kind of increasing their POCUS education in their residency programs? I know there's a lot happening at UW that you've spearheaded, but is this a growing trend nationwide?
Yeah, great question. Even taking it a step back further, emergency medicine requires really kind of a rigorous point of care ultrasound training pathway as part of their residency training. Internal medicine has not created the same requirement. However, American Alliance of Internal Medicine has recently put out a statement supporting routine curriculum and point of care ultrasound, and they actually created a pretty great roadmap of what studies to include and how to include those studies in resident education. Offhand, I think it's something like 60 to 70% of programs have intentional point of care ultrasound curriculum, and that number hasn't really changed much over the last couple of years. And the reason for that is it is intensive, it's expensive, and it requires a particular skill set that if you trained a few more years ago, folks just really didn't have the opportunity to learn ultrasound during their training.
I see. Well, hope for the future. It sounds like that this is the way of the future.
This is the way. Yeah.
Awesome. Well,
Yeah.
I think that wraps up our session today. Thank you, Dr. Shepard, and to all of our other presenters as well. And to our audience for attending today and for taking the time out of your busy days. There will be instructions for claiming CME on the Washington ACP website. With that, I think we're at a wrap. So thank you again, everybody, and hope you have a great rest of your day.